Good afternoon, everyone. This is Joe Kahalski. I'm the CEO of WISHIN. We have a number of people on the line, but we'll give folks another minute or so, and then we'll get started. Okay, we'll get started. Again, this is Joe Kahalski. I'm the CEO of WISHIN, and appreciate everybody who's taken time to join us today. We're doing a series of dialogues with our clients, and this is the beginning of our effort to more formally kind of engage with the local public health departments. Obviously, we have a number of local public health departments that are our clients. Others, and many of those are joining us today. Others who are not yet part of the WISHIN network are also represented. So let's go ahead and look at the agenda. I'll introduce the other WISHIN folks who are on the line. I'll have probably too many of the in the audience to go through everybody, but we're certainly glad you're with us. And if you'd like to use the chat function to kind of introduce yourself to the rest of the group, you're certainly welcome to do that. We'll talk about a little bit about status quo of WISHIN today, and looking forward to our new technical environment that we're calling WISHIN 2.0. Just gonna take a minute or so to talk about the state's pay for performance program and how that is positively affecting the number of participants we have and the depth and breadth of the data that we have or will have soon. And then we'll take a look at the results of the survey that many of you saw and completed. We appreciate that feedback. We'll look at what you told us about what's most important to you, the value you're getting from the WISHIN relationship, and some suggestions for doing even better for you and your colleagues. So we'll dive into that, and then just take a minute or so at the end after we deal with questions to talk about how we do this, how we keep this conversation going into the future. So again, welcome. Let's go to the next slide and just orient you to who's here from the WISHIN team. Besides myself, we have Steve Rotman, our Chief Operating Officer, Laura Witter, our Project Director, Matt Jago, one of our new employees, Director of Population Health and Analytics, Carol Gray-Eunice, some of you have probably engaged with, our Community Outreach Specialist, Tom Roll, our Communications and Engagement Specialist, and Aisling Meehan Fanning, our Executive Assistant. You probably engaged with her too. So I'm going to go ahead and take a minute or so, a couple of minutes probably, to talk about where we are in our evolution and where we hope to be very soon. So Steve's going to handle that part.
Thanks, Joe. Next slide, please. So as Joe stated, some of those on the call today are current participants. They are using WISHIN in our new, soon to be legacy environment. In that environment, there are a number of organizations participating, nearly 2,200 sites of care, about 120 hospitals. The individual or the organizations that are contributing data, there are situations where hospitals such as Freighter and Advocate Aurora, Ascension are adding new types of data. Those new types of data are not available in the current system. They will be available in the new system, WISHIN 2.0. So just want to be clear, when we're talking about new sources of data, more data coming, additional care summaries, notes, etc., that information will be available in the new system. So utilization is growing, data contribution is growing, and we're long awaiting this transition to WISHIN 2.0. And based on the feedback we've received, there's great interest, not only in the information that we provide today, demographics and communicable disease data, but the other points of data, CCDAs and notes, that is coming in the new system. But current state, there is a lot of information that's coming in, and where current participants are sending data, I want to be clear that real-time data does exist in the current environment. There's just a separation as we talk about, just to be, again, clear, when we talk about new sources of data, those will be coming soon by the end of the year. Next slide, please. So it talked about the legacy version, the current system. The current legacy system, we can clarify any points of data from our website as individuals look at our participant map or have had conversations with us and received spreadsheets of who those organizations are and what they're sending, so that there's an understanding of who's sending what today in the current environment and what information will be available in the new environment. But as we look to finalize our transition to the new technical platform, we're looking at moving historical messages and going through the new master patient index or patient matching process to ensure that all of the identities are being associated to the correct individuals, patients, or clients. Completing any historical interfaces. So there's a few organizations where their interfaces, we just need to move them into the new environment. And we are getting very close. That part of the process should be done by the end of July, where customer integrations will then all be in the new environment and staged, in a way that will be available before the end of this year when we launch 2.0. And in addition to that, the final thing is transitioning CCDs or CCDAs or electronic care summary documents. We know that is a current use, and organizations such as yourselves are looking forward to seeing more of that. The last step of the process before we go live will be coordinating with all of our participating organizations that the users that are moving from the legacy system to 2.0 happens seamlessly and the training will be made available at an ad hoc need, but primarily by way of webinar and recorded sessions, so individuals can reference those training videos at their leisure. Next slide. Here's a few snapshots. We can make the slides available so you can see these screenshots of the new system, but you'll see here that we've added a couple alert or alerts to the community health record. It's organized in a different but easy to consume and navigate. Next slide. We have built-in analytics and trending. So those that are working with clients on chronic diseases, you can see how you'll be able to view the information and convert that into knowledge about how these individuals are managing blood pressures or their diabetes and such. Next slide. Another area that we've enhanced in the new environment is managing a cohort. So an individual user of the system can favorite and those favorite patients that then will be made available on this My Patients list. And as you see, the latest demographics are readily available, last ED. So if folks are helping individuals maybe with some needs in their respective communities, both health or social, that maybe they're using ED as their primary care provider or such, you can see last ED visit. So that's just one example of how My Patients can be used. Next slide. And as far as positioning for the future, Joe mentioned new staff member, Matt Jago, Director of Population Health and Analytics. On Laura Witter's team are 2 additional implementation specialists. And those folks, anybody on Laura's team, you might have some engagement with if you're using or plan to use WISHIN to get you access, troubleshoot, or connect interfaces with us. And the last bit is client engagement, where Carol leads today, and we are looking at hiring a new client engagement so that the needs, we hear firsthand your needs. This is a forum, these dialogues, but those one-on-one touch points with Carol and whoever we might bring on in the near future. Next slide.
Okay, thanks,
Hand it back
Steve.
up to you.
Yeah, thanks. Just want to take a minute or so, go ahead to the next slide. You may or may not be aware that through Medicaid, DHS is incentivizing hospitals to participate in WISHIN by creating a pay-for-performance program that essentially financially rewards hospitals that A, participate in WISHIN, and B, participate to the maximum extent that they can. So participation gets some financial incentive associated with it, but sharing all possible data types gets them the most possible revenue. So, and the great thing about it was when it started in 2021, it wasn't just for newly contracted hospitals. It was for everybody, including, those who have been with us since nearly the beginning. So it was recognizing, honestly, that they're doing the right thing, sharing data, and getting a financial reward for doing so. So this initial phase of the program ends this year. We'll see what the details of the program look like after 23. But for the folks who are in this audience, that means that DHS is working to maximize the amount of data, hospital data, and in many cases that means a lot of ambulatory data as well, because hospitals and health systems operate ambulatory facilities as well, and it's the same EHR, so we're getting that data. It's not only hospital data that's coming through. So this essentially works to broaden the network and broaden the types of data that are being shared. So obviously more information is better. And as Steve said, as we're reaching the end of the process to transition to WISHIN 2.0, when that happens, there are going to be a number of new data sources and much more data, including types of data that current clients are not currently sharing, but will be live in the new system. So, for the local public health departments and our other customers, that means much more data and a greater breadth of data and many more participants contributing data. So there's more to find essentially in the WISHIN Pulse community health record. Next slide. So we're going to take a good part of the remainder of this meeting to dive into the feedback that we got from the survey that was sent out a few weeks ago, and again express our appreciation for those of you who took the time to answer the survey, and really looking forward to any color commentary from those who did answer the surveys, or even those who didn't, and their reactions to the feedback that we've received. There are a few topics that I think especially deserve some further discussion, and we'll go into those specific questions toward the end of this segment. So let's go ahead, and again, we'll invite anybody who has some additional commentary or offer some perspective on some of these questions. Go ahead and use the chat. We probably have a few too many bodies to do a lot of verbal commentary, but if you could just use the chat, and we can save some time and give you the opportunity to weigh in. The question was, who was the survey sent to? Just current customers. I think the answer to that is it's beyond current customers. I think we did have some responses from non-customers. Is that right, Steve? Yes.
That's correct. Yes.
So we got sort of both parts of the world in terms of our respondents. So let's go ahead and go to the next slide. So first, before we dive in, saw this recently, and I think it really nicely summarizes kind of what's at stake here, and why WISHIN is important, not only to local public health departments, but to anybody on our network. We saw that we're still collecting, sharing, maintaining information using fax machines, using fax machine, using the paper, has to be entered into a different system by a human being. That's completely inefficient. We often say it is a real shame when we've spent so much money as a nation, as a healthcare industry, to digitize healthcare information. And then we turn around and de-digitize it in order to share it. We print it out, we drop it on a fax machine, we even put it in the mail. That is completely inefficient, and it's really totally unnecessary in most cases. We're probably never going to ban the fax machine completely from healthcare, but we can do better than we're doing, for sure. We don't have to use 40-year-old technology to share information. We've got a massive amount of clinical data that is in electronic format, and it ought to stay in that format for purposes of sharing. So next slide. So the responses that we received to our survey were from 7 local public health organizations: Greendale, North Shore, Oak Creek, Rock County, South Milwaukee, St. Francis, Wauwatosa, and Winnebago. That should be Winnebago County. Next slide. So we did ask the respondents, what was your role in the organization that you're representing? Nurse care manager 4, health director 3, 1 epidemiologist, and 1 communicable disease supervisor. Next slide. We also ask, really of all our clients, when we can get that information, what kind of system are you using? Where are your patient/client records stored? And of course, ideally, when we sign up a client, we would like the information to be bidirectional. Certainly consuming the information that's available from the rest of our network, but contributing data to the rest of the network as well. And I did have a question. I didn't know if Provision or Provision software expressions and the other one are the same. Can anybody tell me about that? Are those the same system? Okay, the answer is yes. And I think that epidemiologist is a typo. I don't think that's an EHR system. And if it is, I apologize to that company. I think that's left over from the other slide. There are situations, and we weren't surprised by it, where there isn't really a system. We understand that. One of the things that we like to do is, if possible, work to integrate the WISHIN Pulse system with the local system that the client is using. And the idea there is that when you are in your own system and you've got a specific patient's record in view, then there's and you want to look for information that exists outside of your organization. The patient context and the user credentials can be shared in the background, essentially, and allow you to jump into the WISHIN system without separately logging in and without separately searching for the patient. So helps in the workflow, obviously. And I will just mention that for any of organizations that are working with us that are interested in exploring that option, we would be happy to talk to you about that. Next slide. Okay, one of the things we asked is, what purpose do you use, for what purpose do you access WISHIN Pulse data? And multiple answers were allowed here. None of this surprised us particularly. Care management, transitions of care, population health, communicable disease, we kind of expected those answers. And I think those purposes sort of rippled through the other questions, the answers to the other questions that we got. Next slide. So we asked what data that's available through WISHIN was accessed most often. And again, multiple responses were allowed here. The CCDAs, the electronic care summaries, near the top of the list here. And that's a theme that kind of came through on many of these answers, the importance of the electronic care summaries. But a broad set of most important data, which to us is great. We have a number of different types of data, and they might be useful in different circumstances. I think this kind of reinforces the idea that we have a wide variety of data available, and it seems, from this limited sample that we're hitting the mark for the most part in terms of the delivering information that is valuable to our public health department clients. Next slide. Then we asked about the benefits, the perceived benefits of WISHIN from, each respondent's perspective. Communicable diseases, we saw that in the earlier slide. The reasons for looking. We're seeing an alignment kind of between the benefits and the reasons that the system is being used. Looks like we have a question. What does CCDA stand for? CCDA stands for Consolidated Clinical Data Architecture. We often refer to those as electronic care summaries. So those mean the same thing. What a CCDA is generally generated upon at the end of a patient encounter or an inpatient stay. It's a standardized way of packaging certain clinical data in a way that can be electronically ingested by a foreign EHR. So, for example, an Epic system, somebody gets discharged from the hospital at a health system that is an Epic client. That discharge happens, the EHR generates a CCDA or an electronic care summary associated with that patient's inpatient stay, and then that information is shared with WISHIN and contributes to the community health record. So the main thing about the CCDAs in terms of interoperability is that they can be ingested into a foreign EHR. For example, the Epic CCDA could be ingested in a Cerner system. They don't have to be, but organizations have the ability to ingest it because the data is in a standardized format. And so it doesn't matter where the patient was seen. Other organizations can bring that information into their own patient record if they've got a relationship with that patient. Those are the benefits, I guess I would, that we heard from our respondents. I guess I'd welcome some reaction or feedback to this. Are there other things that we should note here as perceived benefits among our clients? It's a broad list, so probably checks a lot of boxes for others. But this is something obviously we want to know, and we want to learn, and we want to understand over time whether we're delivering value and providing benefits to our clients. So we're going to use these survey responses as kind of a baseline as we evolve our engagement with our clients, and we'll be taking the temperature from time to time to make sure that the benefits that are perceived now continue to be perceived as benefits, and trying to identify new ones as well. Next slide. So we made mention of our new Director of Population Health and Analytics. Our new technical environment will be much more supportive of analytics and supportive of population health. So we're asking all of our clients to help us understand how could we use that technical capability to your advantage. And we had a wide variety of answers on this. Again, more than one answer was expected, was accepted, I should say. So frequent ED users, diabetics, hypertension, TB, we saw a lot of references to tuberculosis, mothers and children, blood lead, communicable disease. Seems like there's, it's almost an all of the above situation in terms of potential interest in population health and analytics. And again, when we get into the new environment, we will be much more able to support those kinds of analyses. And this is a topic that we will come back to with you and with others to make sure that we're taking full advantage of the new technical capabilities that we will have. Are there other ideas that folks, clearly we have more folks on the call than who answered the survey. So would there be other ideas that we should consider for population health or analytics?
And Joe, I mentioned in the chat, if you're interested in joining the conversation, just raise your hand and we can call on you. That would be the best way to manage those that do have something to say.
Okay. I would just remind you of the new functionality in the WISHIN system, the My Patients functionality. I mean, that's kind of an example of what we can do at a very low level. But if there's a cohort of patients that has your attention for whatever reason, and that's the foundational that's the foundation for analytic kinds of reports. So we will have the ability to kind of accept rosters, if you will, and then deliver or push, in some cases, information that can be done periodically, whatever frequency makes sense for folks. So if this is something that you always wish that you could do for your clients / patients, there's a real possibility we can help you. Is there
there's a comment, I would say, from Benjamin Jones. I believe he's from Waukesha County. Benjamin, would you like to add to the conversation? Otherwise, we can talk about his comment is, I guess I would like more information on what the population health analytics could do. Matt is here, he can speak to it, but also I would say that what we've talked about in the past and foresee in the future, and to be clear, pop health and analytics will be a future state functionality, but we're looking at all the data to see what opportunities are out there. Frequent ED use, communicable disease outbreak, maybe in a region, maybe heat maps or whatnot, chronic disease cohorts, and being able to visualize that for within your jurisdiction, your county. So one piece of feedback in the survey was new pregnancy notifications. That's something we do. Health equity. I'll yield to Matt. He might have other thoughts. But anybody, anything else, please join in the conversation.
Yeah, Steve, I think you did a good job of sort of outlining what my thinking is at the moment. I mean, in my head, there's kind of two initial ways that we can probably present information on specific patient population. One is through patient registries or notifications, which I think Steve and Joe just sort of alluded to. The other is through population level dashboards that track the status of the overall population that you're focused on, or that we create a dashboard for. So looking at rates of disease, what the demographic characteristics of the population look like, how those things change over time. it's the type of thing where I think we could provide information that would allow you to determine, has an intervention we've implemented worked? Are we seeing, again, changes in the structure of the population that we're looking at? So I think those are the things that we're thinking about, and that we'll be looking for feedback from you on as we roll out different tools. And it looks like we're getting some, some comments. So prevalence of diagnosis of diabetes or high blood pressure. I mean, that's the type of information that we're getting today, and that, I think we could certainly think about putting in some sort of dashboard or application. And then I guess this last one, Steve, is probably a question for you. So village limit users that have access to dashboards or data sets within WISHIN. I think the answer is yes, but
Yeah, to steal a phrase that Joe might say, this would be like, do you want fries with that? So you have your baseline service, or WISHIN Pulse. We can add to or bolt on different services. As I mentioned, it's future functionality. We're looking at what services, what use cases, but also the pricing structure of what this might look like. There are integrated analytics and pop health that we can, or dashboards that we've integrated. So identifying what is included, what is additional to the subscription service.
Yeah, I think, Steve, the question is, for the population level dashboards, would there be the ability to limit users to only have access to the dashboards versus the entire data set available?
Oh, I'm sorry. Yeah. So yes, there as well. Absolutely. Because, and in some, maybe many scenarios, that data would be de-identified, and unless, if there's not a treatment use case, it could be a de-identified population or a cohort. And then where there is a treatment relationship, an identified or proven relationship, you could dive into specific patient identifiable analytics.
Yeah, and I would just say that in general, our system, even our current system, has a number of different roles that can be assigned to, each user. Each user would be assigned to one role, but a number of different roles to choose from, and those roles kind of define which information is available to those users versus not available to those users. So that's a concept that we're very familiar with and already administer. So something like that with respect to, dashboards and analytics certainly would be part of whatever we would build. A couple of new messages here. Some way to see variation in population level by zip code or census tract. Zip code, I think we could probably easily map to census tract. We do have zip code for everybody. And that's, I think a matter of crosswalking the exact address to a census tract. Did you say there's a mapping function for heat maps? We have the data that can allow us to create something like that. That's not something we have in the current system. Another question, do you have capacity to help recruit healthcare systems in our jurisdiction to join WISHIN? If not, all health systems are currently part of WISHIN. Or could we work collaboratively with you to get the remaining systems on board or to provide more data? Yes, yes to both. Yes, we would very much like to be part of a three-way or more than three-way conversation in various communities. I think, demonstrating that there's a real demand and need for that data outside sort of what those systems might consider the normal sort of healthcare environment just strengthens the case for participation. So we would very much like to be part of conversations like that, and would be happy to follow up with you. I notice that's Rock County. One of the entities that we're going to be bringing on in the new environment is Beloit Health System. So that's something that's not in the current system, but will be. We have SSM, we have Mercy, but only barely. Mercy is contributing ADTs only, and that's mostly the patient demographic information with a little bit of high level clinical data. Will the new update include treatment? For example, medication that was prescribed to a patient for an STI. I don't know that we will have prescriptions. We'll have prescription fill information, a lot of cases, especially for Medicaid. Steve, Laura, do you know if we can derive an order from the data that we get?
It's not necessarily an order, but
Okay.
what we will do is the care summary documents, the CCDAs that we receive from our customers. If those medications are listed in that reconciled med list, we are putting that into we're parsing that out into our community health record and deduplicating it. So when you go into our new system, you'll be able to see two different sets of medications. You'll have a tab for filled medications that were sent to us from the payers, and you'll have a tab for the reconciled med list that was sent to us from providers. So you'll be able to see both of those. And so if it was prescribed and they put it in the transition to care document, it'll be there, even regardless of whether or not it was actually filled.
Right. So I guess it's potentially possible we'd have to take a look at it where we could identify a difference between the med list and the filled meds. I think that would be the gap. It sounds like what you're getting at was a medication prescribed but not filled. We could do that. I think that's not something that we've explicitly looked at, but seems like we could potentially make that work.
I will add to that a condition of participation that we have in our contracts with health plans or payers that are using WISHIN Pulse for the four approved purposes, there is a condition of participation that they contribute data, and one of those elements of data contribution is medication fill history from their PBMs. So we have 2 or 3 organizations that are doing that, but not on a consistent basis. Once we get through the transition, that'll be a top priority, is getting payers to send their fill history. So not just Medicaid, but also the other lines of business that our health plan participants are using.
Yeah, and that's sort of the private payers. We do have Medicaid prescription fill information dating back a long time. So I know that's not exclusively the folks that local public health is dealing with, but we have very complete information on filled prescriptions for the Medicaid population, and we're building out the private pay. So there are a couple more comments there, Steve, and I missed those.
Nick was saying that, or asking, will there be a way to break down population level data by insurance coverage, thinking about patients who have private insurance versus Medicare or Medicaid? I don't see why that would be a problem to break that out. But again, it goes into the prioritization of use cases. So we are recording this. We'll have this information is in chat. So as we start building the use cases, work to bring different work groups together so that we can prioritize all of these use cases that you've mentioned here. And Nick, again, short answer, I don't see why not, but
Yeah,
we just
and
have to get
I would ask Laura to weigh in here. I think one of the variables here is the ways in which the providers we're dependent on the providers identifying the payer, and in many cases
Yes.
do that. But it's not as standard as it could be. So
Right.
yeah, so I think we could do something there. We'd have to take a closer look at what would you call it? The way they're identifying the payer. Is that
Yes. Yes. So when we get messages in from our participating organizations, they provide the payer information. They send what they have in their own system as the payer name, the payer, and their own codes and their own plan names. But there is not a standardization at all across organizations. They load them in based upon their own way of identifying them. So that does pose somewhat of a problem identifying,
yeah.
there's like six, there could be 6 different ways they identify Molina and 6 different ways they identify the same Molina plan from 6 different organizations. So that does pose somewhat of a problem. There are other ways we could possibly deal with some of that, but it because there's no standardization across health systems as to how these how they're referred to, it's really hard to completely generalize by different org, unfortunately.
Yeah, and it might be slightly less complicated when we're talking about the distinction between private pay, Medicare, and Medicaid. Some of the identification of the payers is like some payers are only Medicaid, so we would be able to safely say, well, that's Medicaid. But of course, in other situations, there are payers who have a Medicaid line of business, but it's not exclusively what they do. But go ahead.
Medicaid versus non-Medicaid, there are some other ways by not just by identifying the payer. There's some other fields that we get that could say, like it's called like financial class. And a lot of times we'll have a class that says whether or not it's a Medicaid or whether it's private pay or self-pay. So it doesn't identify the actual Medicaid provider or the plan, but again, those are optional fields. So not every single customer sends it. Although we are going to be kicking off a governance group that Matt is running, and I'm kind of being part of it, that will talk about those types of things and talk about what kind of data is being sent by our providers to help with some of these use cases, and what do we want to strongly encourage providers to send in the future. So one of them would be that financial class. So we can separate out Medicaid versus non-Medicaid versus self-pay.
Right. And there's a question that you answered in the chat, Steve, but we should probably, talk about here about the difference between the apparent difference between the CCDA data and the other community health record data.
Yes. So Ray's question, and I'm just finishing another response about WISHIN 2.0. So when the WISHIN team was looking at opportunities of expanding the current data set and data available to participants so that you didn't have to sift through multiple CCDAs to get the information you were looking for, how can we pull that information out? So in our terms, that would be parsing that data that lives in the CCDAs because it's in a standard format, parse that information out and store it and then display it in a way that's seamless to your experience of WISHIN. So the ability to take those CCDAs, pull out medications, put those in a medication reconciliation list within the community health record. I think in a previous slide, if we can maybe very quickly, Aisling, go back to the slide of the patient summary. It might have been maybe 2 or
Keep
3
going.
on the list.
Yeah.
But keep going. As she's going to that, we're also pulling out the lab information and putting it under the lab results. A couple more or a few more slides.
It's in the WISHIN 2.0 section. Yeah.
About 2 more slides right here. So you can see here visit history, and then kind of grayed out as allergies and medications. Under medications will be the payer fill history, so Medicaid and the other commercial payers, but also the CCDA med list. So it's the list from that a reconcile list from that visit or encounter. So that's where you'll be able to find that type of data. Again, if you're interested in seeing a demonstration of this system or anybody else, we're happy to get that scheduled. So last thing from Beth, would height and weight be separated into another area or just within a care summary? Height and weight will be added to the visit ID that you're seeing here. So there's where it shows 225511. There's the face sheet plus additional data. So within that visit, you'll be able to see the vitals from that visit, and that's coming from, Laura, correct me if I'm wrong, either the ADT or the direct message, the ADT message, and or the CCDA. So yes, we're pulling that in. And I would say as part of, here's maybe another opportunity for population level data or data sets that we can provide. If your public health entity is interested in pushing data to you, that we could look at that. You send us a cohort of patients or clients, and we can turn around for those patients. Here's the height and weight, here's the medications in a flat file that you can ingest in your system. Or we could look at different ways to display that for you. So many different use cases. The possibilities, I'd say, are endless for what we could do in the future here.
Right. And then there's a question about the timeline for population health component. And that is, well, the launching WISHIN 2.0 is on the critical path to everything that we're talking about population health wise. And then we have to go through a process that's really use case specific, understanding what the desired output is, and assessing the extent to which the data that we have meets those criteria. And we're going to be looking for a lot of feedback from users like you and other types of clients to help us walk through exactly what kind of information is most valuable. So hard to say when this all becomes reality, but we're starting the process now. We're trying to introduce to all of our clients the fact that we will have this capability, and we're going to, and part of it, we mentioned that the data quality and completeness, the data governance effort that Matt is leading, that's part of it too, looking to increase the standardization of the data that we're getting. So a lot of moving parts here, but we appreciate your interest, and we will be looking to you to help us define what's most valuable and what's most technically feasible. And I don't know that we see an end to this process. This is going to be a continually evolving process where we will have different types of deliverables. And certainly there's technology that's foundational to all of it, but the specific outputs, we just have to walk through a process, and we want clients at the table as we're doing that. Looks like we had a couple of more comments here.
Yeah, I would say the last comment is from Ray. Is there a plan to interface WEDS or WER within with WISHIN in 2.0? Well, I'll start with the latter. WER is visually integrated. We have a connection to WER in the current version of WISHIN, and WISHIN 2.0. You'll see it in the slide that's open right now. Immunization. That's a single click into the schedule and history directly from the Wisconsin Immunization Registry. So within one click, you can get to a patient's immunization status. WEDS we've had, but it's a process to continue the conversation with DPH at the state level, how to integrate with WEDS. Some feedback from you all about the importance of that and how we can better partner would be beneficial. But I would say DPH has never been more engaged than they are right now. So we're making advances, and this is new to them to make this data available to us if that was possible. So more to come. I think additional conversations of how important it is to align the clinical history that we have and the WEDS data would be important so that they can understand that context.
Yeah, I would say that in our view of the information that DPH collects, including WEDS and immunization information, in our view, that data should be part of the community health record. I mean, it just makes sense to us. It's not, you just can't snap your fingers and have that happen. As Steve said, I think DPH is more engaged now than at any time in my memory, and I've been here since the beginning of WISHIN. So they're going through a process themselves. They're calling it the Data Modernization Initiative, and so certainly we are part of the discussion that they're having in terms of what does the DPH of the future look like. So I'm optimistic that information like that can be part of our data universe. For example, the immunization registry information that Steve just talked about, you can click, you've got Tony Stark up, you can click right into Tony Stark's immunization history and schedule information. But that data doesn't live in our system. That data, I mean, we certainly do have some immunization data that comes in from our data contributors, but as I'm sure you all know, immunizations can be administered in a lot of different places other than a doctor's office. And the only place all of that information comes together really is at WER. And so it makes a lot of sense for us to have all of that information and have WER contribute that data to the community health record. But frankly, I think, they're looking at what is the WER of the future, not the WER of the present. And so I think our opportunity to engage there is with the WER of the future. And I think that general statement holds true for many other types of data that DPH deals with. So did we get to all the comments? I think we did. Hopefully, if we missed something, don't be shy, repeat your question. There were a lot of them coming through pretty frequently there. So let's move on to the next slide. I think we've already been here. We asked if there were other topics. We gave, some choices for population health and analytics, and then asked for others that we didn't have on the list. And as Steve mentioned, somebody said it would be good to be alerted of new pregnancies. and presumably that would be a function of an actual roster that we got. I mean, if there's a roster of patients that you're taking care of and you wanted to get notified when there was a diagnosis of pregnancy, we would have to have the roster at first, but I think that's probably doable. And then overdoses, that's a diagnosis, I assume. So that would be something potentially, but again, it would probably be downstream of us getting a roster of some kind and understanding, which particular patients that you are tracking. And then we could probably do that.
I would just add, Joe, to the opioids and other substance overdoses, is that we've had a few conversations with individuals at the OFR, the Overdose Fatality Review Board, where there is some conversations about how that data could be made available to the boards, or for general purposes in the event of an overdose. Laura and I took a ride with an EMS provider in the Waukesha area, I guess. And we've heard how important it is to have that overdose information or the history of that, or administration of Narcan. So that's something that has been top of mind for us, and we'll continue those conversations as we can look into these opportunities post go live with 2.0.
Right. One reason we want to get better integrated with the EMS entities, and we're working with the City of Milwaukee Fire Department to essentially capture data from their system and use that to populate the community health record. Administration of Narcan will probably likely be, part of the data that we could potentially capture. So next slide. So we asked our survey respondents, to kind of articulate the value in terms of the conversations, the communication that has to take place between local public health departments and providers. And none of this is that surprising to us. It kind of supports that initial quote we started with this section with. I mean, we're eliminating a lot of manual and often asynchronous communication between public health departments and providers. In a lot of different contexts, you need to track down clinical information, and it may be telephone tag for a while, right? So we've got real-time information, a shortcut, benefits to both sides of the equation, right? Both the entity that's seeking the data and the entity that has to provide it. So, and the other thing here that kind of stood out to me is an acknowledgement that, we may not have everything you need to know, but there's a lot of it that can be kind of set aside, and you can focus on, whatever it is that you still need to find out, because you've already checked a bunch of boxes with the information that you were able to access. The other thing we hear here in this survey, and we've heard from others, like Medicaid managed care plans, is how important it is to have current contact information. There's a non-negligible number of folks who are very mobile. They have different phone numbers, and they live in different places. But when they have a medical encounter, we're capturing a lot of that demographic information, and just the ability to communicate with patients or clients is very valuable. I mean, everything starts from there, right? And so even though it's not clinical information, still proves to be very valuable. So next slide. And we asked, what are the opportunities for better alignment or opportunities for us to deliver additional value? We talked about population health metrics, specifically this comment, updating dashboard or dashboard creating tool within the site. That's certainly something that we have envisioned for the future. So that's not inconsistent with our vision. Consistent availability of care summaries. We're going to dive into that topic in just a minute or so. We also heard the issue of the drugs that were prescribed versus drugs that were filled, and the pharmacy involved. And I think we do have, in both cases, do we have the pharmacy or only on the prescription fill? We do have the filling pharmacy.
Yes.
In the community health record, yes. And then the idea of enabling or facilitating public health reporting. We're going to want to dive into that second and fourth bullet point a little bit deeply, and I think a little bit more deeply, and I think that is the next slide. No, just one more here. We asked about, we'll stay here. We asked about health equity. It's something that everybody seems to be talking about now, not just public health departments, certainly Medicaid, managed care organizations, and others. And so the idea was, one of the ideas was, could we help you determine the distance, driving distance, presumably, between residents and the providers that are involved, including, the insurance status of the patients, and another idea of including a field for pronouns or preferred name. I'm not, Laura, I'll ask you on that second one. Is that something that there is, that there's a field for in an ADT message, or is that just something that is not typically provided in the data that we get?
There is a field for alias, which is what some of our customers, which is what some of our customers have been using for preferred name. So the problem is with some of this is that HL7 standards have to catch up to a lot of the current things that are going on. Pronouns, there really isn't a field that designates like the preferred pronouns, like, his, her, they, theirs. There's a prefix field, but that really isn't what this is for. So until there's an HL7 standard that is put into place, we won't have room for it. We won't have a place for it because there's no standard. But preferred name, they're using an alternate field.
Yeah, current state is we might be able to capture the preferred name if it's provided. At this point, what typically comes out of an EHR is not capturing any kind of a pronoun designation. But I'll pause here and ask if there are other ideas in terms of, the data that you need to capture or use related to health equity that we might be able to help you with.
While we're waiting on those, Joe, we do have a question from Erin. She says that I've had to look up some patients that have died, and some have DOD. I'm not if that's determination of death, maybe. I'm not sure what that is.
Date of death.
Okay. And some do not. Do you communicate with medical examiner? How does that information get updated? Laura, I'd ask you date of death. I mean, if it's coming from a hospital and that's where the death occurred, I assume we would have that, but
yes. So the hospital system will normally send us an update with there's an indicator in HL7, an indicator of a death indicator, and then the date of death. So if they send it to us, we display it and we change that status. And it does show that the patient is deceased and the date of death, but it has to be sent to us from someone. So if, the patient didn't, pass away during a visit or while they were inpatient somewhere, none of the health systems may know about that either. And we don't have any kind of interfaces with medical examiners to like get a listing of all of the people who passed away or anything like that.
Well, and not every death involves a medical examiner. I mean,
That's true as well.
I mean, and I think this really implicates vital records part of DHS, where there's a possibility we might be able to integrate with those folks, but that's not within Medicaid. That's not within DPH. I think that the vital records is a separate area, but yeah, I think in general, if the death occurs in a facility that's part of our network, we would probably have some indication of that. It's a discharge status, sometimes it says to home or to rehab or to, deceased, something like that. But in terms of a death just happening at home or something, that is not typically something we would get from a provider. But all of these are interesting questions that we would love to explore with you, because the data is out there somewhere. And we've often said, I mean, we're a little biased, but it'd be great to have a place where all that data comes together, right? And we would raise our hand and volunteer for that. So we will definitely revisit those kinds of questions as we continue our conversation with you and others. Let's go to the next slide. How can WISHIN do better? Public health reporting again, and looking for videos and tutorials for using the system. We are, that is on our roadmap in relation to, launching 2.0. So we will be doing some more intensive kind of training and orientation on the new system. The public health reporting, let's go ahead to the next slide. That's one of the two things that I think really deserves a deeper dive with this group, and is something that we'll probably keep coming back to. Really want to understand the issue that people are finding with the care summaries, because some of the comments sort of lean one way versus another, and want to get some broader input on this. I mean, we are aware, of course, that some providers are contributing care summaries and others don't. So that concern where, you can find a care summary if provider X is involved and you can't with provider Y. I mean, that's not news to us, and we're certainly working to improve that.
Joe?
Yes.
Can I address the second bullet?
Sure.
Of the some respondents implied that fewer care summaries are available now versus the past.
Yeah.
My guess, one of our largest contributors of data had an issue for a little over a month where their care summary interface was broken and down.
Oh.
So that did get back and we did get a lot of feedback saying, the data is missing now because they are one of our largest healthcare providers. That data is now being sent again. So there was a technical issue, but they've gotten it fixed. We're trying to work with that organization to see if they can send us data that was missed. I don't 100% know for sure. But my guess is that when you're talking about fewer care summaries are available now versus the past, it was the major healthcare provider.
One provider.
Okay. Yeah. Our largest healthcare provider contributor.
Rhymes with Schmorora.
So, yeah, exactly.
Right. Okay. So yes, I mean, this is something that we've heard consistently that, well, number one, the value of it makes clear the value of care summaries. And that is one of the things that hospitals have to do. Hospitals and health systems have to do to maximize their P4P incentives. So we've actually been adding more of that kind of data, and all of our new clients are signed up to do that. Again, the floodgates will open soon when we move into the new system. So would welcome any additional commentary from the folks on the line about the care summaries and what the specific issue is, and what the specific providers that you really hoped would be contributing care summaries but aren't. We'd be happy to carry that message or deliver that message jointly with you if there are specific entities that are kind of a big hole in terms of the information that you would be looking for. So I know of several respondents cited this issue. What else do we need to understand about that? One of the issues I wondered is are you finding that depending on the provider is the content of some of the care summaries, does it vary from provider to provider? And is that part of the issue that people are confronting? Don't know. Okay. I guess all I'll say on this is that we are continually encouraging our clients who are not sharing CCDAs to do so. And you can count on us continuing that push. But you will see when we launch the new system, a large increase in the amount of information that's available from care summaries because of the new clients that will be, and the existing clients with new interfaces that will be, live when we get into the new system. The other thing that I wanted to take some time with as we're getting close to the end here is the public health, the reference to public health reporting. Really would like to hear from your perspective, what are those pain points that you're hoping we can help with? How can we help? We talked a little bit about, WEDS and WER before. What would the ideal future state look like to address the concerns that you have related to public health reporting? It's like we have a
couple questions here.
Yeah. While folks are thinking about that, why don't you go through those, Steve?
Ray was asking, I'll summarize, funding opportunities and working with DHS to cover the cost for local health departments, knowing how DHS is covering ADRC's access to WISHIN. This is a question from our health officer.
Yeah, and I will say that we had a proposal that we hoped would be included in the state budget bill this year to do exactly that, among other things, but we weren't successful. We're not going to give up, but for purposes of the budget, that's probably not going to happen. So were there a few?
Yeah, Beth was asking, so if there's a hospital system using WISHIN, can affiliate clinics data also be automatically entered? The answer is yes. In many cases, depends on how those organizations are partnered, if they're affiliates or wholly owned, but we have many situations where that is accurate. An Epic instance is used by affiliate clinics, and that data is coming out including clinics, part of that system. That's happening today. That would not be separate.
Right. Yeah, there are a few exceptions, but for the vast majority of our participating hospital systems, we are getting their ambulatory data along with, it's all coming from the same system. And as Steve said, even for clinics that aren't literally part of that system, but are using the Epic instance, they're independent otherwise, that data is coming in as well. So I thought I saw a couple other questions.
Yeah, Nick is interested in current diagnoses. Some of the data they get is 2 to 4 years out. Yeah, that's why we exist, Nick. That's why we're here. So if there's something we can do to fast track, get you participating, we can get those conversations re-going with Waukesha. We recently had a conversation with Waukesha, so I'll reach out separately. And then Cindy had a comment that HSHS system would be valuable to have in. HSHS data is live in the new system. Keith on our team, kudos to Keith. He got them live last week, maybe 2 weeks ago. The caveat there, not live in this current system, live in the new system, live in 2.0. But it will be available. But caveat with HSHS is many of the ambulatory clinics are part of Prevea, and Prevea needs a bit more. They need a bit more attention and TLC to get them in.
Yes. Yeah, and that would be coming from that same EHR system, but to this point, we are only getting the hospital information, not the ambulatory information. That's an exception to the rule that we just talked about. For the most part, we would be getting all of that ambulatory data, but HSHS/Prevea is an exception. There's a question here: can WISHIN be available for FQHCs? Well, yes, we have a number of what we would call safety net clinics, not all of which are FQHCs, but many of which are. So yes, they are part of our network. Many of them are. So, well, folks have thoughts and have some specific information they'd like to share around care summaries and the public health reporting issue. We'd like to hear about it. Shoot us an email or contact us. I was especially interested in the public health reporting comment because, as I said before, I mean, we certainly see WISHIN as a really important part of the transportation and transportation of public health data and providing access to it. So one of the things we need to understand better than I think we do is what is the role of the local public health departments in terms of in the public health reporting realm. Certainly providers are required to report certain things, syndromic surveillance, the WEDS data, the reportable labs, things like that. I think we need a more thorough education on the role that the county or municipal public health departments are playing in that process, because I think our interests are aligned in terms of facilitating a more automated way of moving and accessing that data. So if there are specific pain points that we can talk about in terms of alleviating for the municipal and county public health departments, we would love to have those conversations. Okay, that's an open invitation to educate us and help us understand how we can help you. Next slide. Just one more slide. We are establishing a number of these dialogue groups, and we anticipate having regular meetings like this. So we're looking at a quarterly cadence, and 2/3 of our respondents said they'd be willing to do that. Obviously, it's not mandatory, but we think it's important that we're available for these regular opportunities to communicate with each other. So we will be in touch with you, in the next month or two about when we'll get together in the next time. Hope you found this useful. I hope there is a lot more. I know there's a lot more that we can talk about in the future. So again, thank you for joining us today. Thanks to those of you who took the time to respond to the survey. And if there are folks who, for whatever reason, didn't have an opportunity to weigh in on the survey, and if you'd like to have a chance to weigh in that way, we could certainly arrange that as well if you'd like. Any final questions or comments for us today before we wrap up? I know there are many participants on this call whose public health departments are not yet part of WISHIN. We would certainly welcome an opportunity to talk to you about, what that entails. If we get the paperwork out of the way, we can have you set up in the existing system pretty darn quickly. So if that's something that's of interest, we can get that rolling, and you could be using the data and accessing the data very quickly. Okay. Thanks, everyone. Very good discussion, lots of engagement in the chat, and hopefully we answered all your questions. But we're always here. You can reach out to any one of us if you have other things to offer, and especially between meetings. So hope you have a good rest of your day, and we'll talk to you again soon. Thank you.